goal-directed perfusion. Thank you very much.
I'm just going to give an update on goal-directed perfusion. Basically, what's happened in the last couple of years since we presented in the last meeting. Well, basically, the whole reason for talking about goal-directed perfusion is providing the optimal oxygen delivery and tissue perfusion during cardiopulmonary bypass. So that's basic definition. And Marco Ranucci basically started coining the term back in 2005 when he looked at independent risk factors for acute kidney injury, and he found pump flow, lowest hematocrit, and lowest DO2 were independent risk factors. With a DO2 of less than 272 mils per minute per meter squared, basically was associated with severe acute kidney injury and increases in serum creatinine. And the low DO2 is the most sensitive, followed by hematocrit and blood flow rate during cardiopulmonary bypass. And then in 2011, Philip and Ranucci basically further looked at oxygen delivery and CO2 production during cardiopulmonary bypass in a study of 350 patients, and basically found that the DO2 index over your VCO2 or your metabolic requirement, if that's less than 5, then you have an increased likelihood of acute kidney injury, which again was more specific than hematocrit, but all had a negative predictive value of over 90% DO2, the index, and hematocrit. So that leads last year, almost a year ago now, in the Journal of Thoracic and Cardiovascular Surgery, Marco Ranucci again looked at a randomized control trial called the GIFT study, where they looked at goal-directed perfusion to reduce acute kidney injury. And basically, they just used a strategy of maintaining your DO2 greater than 280 mils per minute per meter squared. So basically, they randomized 2 groups, one control group, this was 9 centers, one control group, and the only difference between the two basically, again, was the target DO2 in the treatment group, and the transfusion trigger in the treatment group was the hematocrit less than 21% with an SVO2 of less than 68%. Everything else, the control, was basically center-specific. If you look at the outcomes, the primary and secondary outcomes of the overall population, they were able to find acute kidney injury stage 1 significantly different in the control arm versus the goal-directed therapy arm. And if they were look even further at taking cardiopulmonary bypass times between 1 and 3 hours, this injury was basically more pronounced. So the acute stage 1 injury was more significant, basically, and any creatinine increase also became significant. There were no differences in secondary outcomes, and even if you look at transfusion rates, which was very interesting, transfusion rates were not statistically significant in these groups, which most people would think that maybe in the goal-directed perfusion arm there would be a higher transfusion rate. So their conclusions were basically, yes, goal-directed perfusion prevents minor acute kidney injury in low-risk patients, but unfortunately did not suggest a change in clinical practice, and so further studies are basically needed. The one thing about this study, though, is we had 9 sites, and there's a lot of clinical site variabilities. And if you look at goal-directed perfusion, just the calculation alone, 1/3 of the sites, or 1/3 of the the patients, I should say, GDP was calculated using the M4 by Spectrum Medical, and 2/3 were used by calculated by Connect, which is a LivaNova product. Hematocrit and hemoglobin, there were a number of different devices that measured hematocrit and hemoglobin. Some centers use roller pump, others use a centrifugal pump, which again, a roller pump is a calculated flow. Ultrasonic flow centers for a centrifugal pump is actually a measured flow. They have varying priming volumes with wrap techniques and different transfusion triggers for the controls. Which leads me to a nice little study done by Rob Baker looking at the variation in measurement and reporting of goal-directed perfusion parameters in the Journal of Extracorporeal Technology in 2017. And just looking at the calculated parameters alone, so the Connect uses a totally, well, not a totally different formula, but a different formula than the M4. So one uses hemoglobin versus the other uses hematocrit divided by 3. The constant is different in the two formulas, and the PaO2 contribution is used in the Connect, which is not used in the M4 or the, now it's the quantum heart-lung machine. So this can result in varying a different, basically different level. You know, so you get a difference of about 20 millimeters or 20 milliliters per minute of DO2 in the M4, lower than what you would see in the Connect system. And likewise for VCO2 measurement, you see even more, up to 40 milliliters per minute. So, so basically what we're trying to do is, you know, these devices were intended for trending, and now we're trying to make precise measurements from them. And as well, we haven't really validated any of these devices against, you know, the laboratory standards. So if you look at it, the accuracy, if you want to look at accuracy and precision, you know, we want that, you know, we're measuring something that's very, we have a very low accuracy and low precision. And we really need to get to, you know, at least high accuracy and probably low precision just by validating these devices. So it becomes very difficult, I think, to compare apples to apples and oranges to oranges. We've seen this paper many times during the course of this meeting, and you know, the recommendation for goal-directed perfusion, it's a Class 2A B recommendation, so you know, goal-directed perfusion should be considered. And also, I think if you're going to consider goal-directed perfusion, I think you really need, as a department, you know, to step back and develop your own algorithm. You know, there's ways to do this before cardiopulmonary bypass and during cardiopulmonary bypass. So before cardiopulmonary bypass, you want to optimize your DO2, so limit hemodilution, decrease primer volumes, probably adapt MiECC strategies, you know, all leading to avoid unnecessary crystalloid use, maintain your DO2 above 280 by either increasing flow, ensuring proper cannulation, which I think can sometimes be a problem, something that's very overlooked. Increase your PaO2, consider ultrafiltration if things aren't working. And then look at your DO2, VO2 index. Keep that greater than 5 to avoid anaerobic metabolism. Look at your lactates. You know, make sure that they're adequately low. Maintain your anesthetic level. This is something else that will affect this. And if all else fails, you might want to consider decreasing your temperature. And then finally, looking at you know, your red blood transfusing red blood cells. So thank you very much.
Thank you, Cyril. Anybody want to comment on this?
Yes, I would like, especially on the accuracy, because you're completely right. But I think there is a very high responsibility on the companies who actually provide those devices. Because I think if you look very carefully to the original publications from Ranucci, it's quite clear that there was a correction for temperature, dryness inside his carbon dioxide formula. For example, this is not done with every device, but if you ask to some companies to provide the formulas, which I would find clinical courtesy, it's very, very difficult to get them. And the same is true whether you're using a blood gas analyzer, which is actually measuring the hematocrit, or whether it's measuring hemoglobin. Because again, you will need to use a correction factor. So I think when you use this type of techniques, it's very important to understand the basics of it, but also the limitations of what you're using yourself. And I think there sometimes we make a mistake. We believe that you can just take it over without looking to the instrument. The same is true for NIRS, as we have seen, but also for many other techniques. And we should be more carefully in how we employ these new techniques.
No, absolutely. And I think, you know, to go even further, I think when we're reporting or presenting this data, we should be presenting exactly how this is measured. Because, you know, as a layman out there reading these papers, you're going to assume that, you know, if I'm measuring my DO2, if the measurement is 280, excuse me, it doesn't matter what device you use, it's 280 is 280, which is totally false, right? So I think...
That's true, but it's not only that. I think people believe that they just need that one value. I'm really very disappointed by that, because goal-directed perfusion actually is an online multivariate analysis. So it means it needs to be combined with other variables. I think VCO2 is extremely important, because sometimes the first indicator of a bad perfusion is a respiratory quotient which is increased. And that's sometimes even when you have 280 or 290, because that's the minimum value. It doesn't mean that a patient can't be at a higher level under a given circumstance. So also NIRS, I would like to have that included in this algorithm. And only then I think we can say that we have a really goal-directed perfusion.
Just would like to add a comment about the accuracy and even more about the synchronization of trend monitors versus laboratory instruments. So we have to be aware as well that depending of the brand of the laboratory instrument we are referring, we can have 10 to 15% different measurements. So for sure, when you synchronize your trend monitors with, let's say, one brand of laboratory instruments, maybe you are far away from the reserve coming from the lab. But if you perform exactly the same blood sample with another brand of the laboratory instruments, maybe you are very close to the reference of the reserve from the lab. So we have to be aware as well about this discrepancy between laboratory instruments and trend monitors. Yeah.
Absolutely.
Yeah.
I just have a sorry. I just have a small comment.
Go
yes. Ahead. I want to support completely 100% what Dr. Sommer said, and I think also in regard to the industry, they have to be aware that if they are not going to share their algorithms with the field, that there's also a liability issue. Because if people start to do things based on the number that's popping up on the screen, and it's turning out to be 30% different than the real value, then the question is, if something goes wrong, who's liable? So I think it's just as drugs, there's a safety issue, and there's a transparency issue, and if companies are going to not share their algorithms so that we can scrutinize the stability, linearity of the algorithms in relationship to real values, then I think there's an issue to be discussed.
Excuse me, I would like also to give some comments and more also question. First of all, I completely agree with Dr. Sommer about that we cannot apply only to one number. This has this always multi-variable case. But to big my surprise, one of the most important indicators of quality of perfusion, this oxygen consumption, is continuously missed from discussion and evaluations. We studied the oxygen consumption during perfusion. We had found that it could be fluctuated from 70 to 50% from expected during perfusion, and this could be also one of the very important parameters, very important factors which influence on the predictive value of oxygen delivery and in prophylactics of kidney and organ failures. Yeah, I would like to ask Dr. Serrick to comment this test, what he thinks about the influence of oxygen consumption.
No, I think you're absolutely right. I think there's a number of factors that we could be, or we should be measuring to look at the quality of perfusion altogether. So oxygen consumption, VOC2 production, NIRS, all these things are taken into account. Goal-directed perfusion is, I think, totally is different for every center that you look at. A lot of centers, you know, I know a lot of centers in Canada. They look at your flow, your pressure, and your venous saturations, and that's considered that's their goal-directed perfusion, which is quite a little bit different than what we're discussing here. But
well, at least it tests by time.
Yeah.
Okay, thank you.
Thank you. If there isn't anybody else, we'll carry on very much on the same subject with John Murkin. John.